I want to start by defining what a single-payer system is. The label single-payer is being increasingly muddied up, in part by people who are defining Medicare for all as something we don't think it is, and in part because there are bills like Bernie Sanders' bill, which has got serious problems with it, that's also being called a single-payer bill. So I think it's really important that we learn how to draw a bright white line around what a single-payer is. It has 4 features. Number 1, it means one payer replaces multiple insurers. So at the national level, Representative Jayapal's bill means the Department of Health and Human Services is going to replace 1,000 to 1,500 insurance companies. It's very unclear how many insurance companies we have in this country. It's probably around 1,000. And in Minnesota, it means one payer replaces probably 300 insurance companies. The second feature is that the one payer at the federal level, I'm going to say HHS, Department of Health and Human Services, sets budgets for institutional providers. And you'll see it in some single-payer bills. They divide all healthcare professionals and institutions into institutional providers, hospitals and nursing homes, and then into individual providers, mainly doctors, but chiropractors and acupuncturists, dentists, etc. So the second feature of a single payer is that it sets budgets for institutional providers, annual budgets. Third, it sets a uniform fee schedule for mainly individual providers, doctors. And then fourth, it sets price controls on drugs. And this was essentially the model proposed in 1989 by a group that was new at the time, Physicians for a National Health Program. They're now up to about 21,000 physicians. They were formed in 1986. Their founders are David Himmelstein and Stephanie Woolhandler. Amazing researchers, those two. And the reason I say this is the definition is not because I went to the mountain and I got a scripture and this is what a single payer is. This is the definition because if you mess with any of these features, you reduce the ability of the single payer system to cut costs. It's that simple. I will show you some slides documenting that statement. 1384, Pramila Jayapal's new bill, has all 4 elements. Bernie's is missing the first 3. And in a minute I'm going to show you a classic feature of every single payer bill. Every single payer bill, true single payer bill, will have a statement in it that says, on such and such a date, it shall be unlawful for an insurance company to sell a policy that duplicates the coverage described in this bill. And that usually tells you that you're reading a single payer bill. The trouble with Bernie's bill is he has that prohibition in it, but 4 or 5 pages later, he's got a section that authorizes a brand new type of insurance company called accountable care organizations. And nobody knows what ACOs are, but they act and walk and quack like insurance companies. And everybody overlooks it. Everybody who studies his bill says nothing about it. But people who understand health policy, including PNHP at the national level, and have strenuously objected to it privately. We were very worried when Representative Jayapal said from about June through October, I want to synchronize H.R. 676 with Bernie's bill. We were really concerned that she was going to do what Bernie did, which was to insert ACO, accountable care organization loopholes, in the bill and yet retain that classic statement on such and such a date, insurance companies can't sell policies that duplicate the coverage. Turned out she did not. I was thrilled to read the final bill. I would say her bill is a slight improvement over H.R. 676. It's about 120 pages long. H.R. 676 was 30 pages long. I don't think it needed 120 pages, but a lot of it really is an improvement.